I'm Dr. Jeff Calvert. I'm the Associate Director for Clinical Quality at the World Trade Center Health Program, which is part of NIOSH and CDC. So it's my pleasure to introduce today's webinar, which is titled Autoimmune Conditions in the World Trade Center General Responder Cohort, a Nested Case Control and Standardized Incidence Ratio Analysis. It will be given by Dr. Henry Sachs, who is a highly credentialed researcher. He has both a PhD and an MD, which he received from the Albany Medical College. He completed an internal medicine residency and an infectious disease fellowship, both of those at the University of Connecticut. And finally, he did a postdoctoral fellowship in biostatistics at Stanford University. He has over 25 years experience designing, conducting, and analyzing clinical trials and observational studies, and has been principal investigator on numerous National Institutes of Health sponsored studies. He is currently a full professor of environmental medicine and public health at the Icahn School of Medicine at Mount Sinai in New York City. His talk today is based on a paper which he is the lead author on and was published in the American Journal of Industrial Medicine in 2022. And as you may know, autoimmune disease is a hot topic with respect to the World Trade Center Health Program. Previously, papers on this topic were published by researchers at the Fire Department of the City of New York and by the World Trade Center Health Registry, which is maintained by the New York City Department of Health and Mental Hygiene. But to my knowledge, the paper by Dr. Sachs et al. Is the first published report on autoimmune disease among members of the general responder cohort. So without further ado, it's my pleasure to introduce and to hand the podium over to Dr. Henry Sachs to again present his paper titled Autoimmune Conditions in the World Trade Center General Responder Cohort, a Nested Case Control and Standardized Incidence Ratio Analysis. Take it away, Dr. Sachs.
Okay, so thank you very much, Dr. Calvert, for that introduction and for the invitation to come and speak here. So I already heard the title a couple of times. I guess I don't need to repeat it. This is a study that we did. It's now almost 2 years ago that we published it. And I'm going to tell you a little bit about what we did. So first is the usual disclaimer that this is our responsibility and not the Institute, and doesn't necessarily reflect their opinions or conclusions on anything. And we have no conflicts of interest. These are the contract numbers. We're grateful to NIOSH for funding this, and we're happy to have a chance to share what we found. Okay, and also again, just to reassure everybody, and which is what the journal editors all require, is that we did all the proper, all this is approved by the appropriate institutional review boards at each of the participating centers. And I'm going to tell you a little while about some of the data that we got from Rochester, Minnesota, which, because it's just data summaries, is exempt from IRB approval. Okay, so as you can, I hope, see this, I'm the person who's presenting this, but this is the work of a very large team, as you can see here. And just briefly to tell you about some of their contributions. So this includes the nurses who did a lot of the reviewing of the patient's charts. This includes a lot of the people in the data center who did all the analyses. It includes our colleague in Minnesota who helped us with the comparison data. And there are several specialists who we consulted when we had questions about the diagnoses or non-diagnoses who were helpful. And then, of course, the leaders and the staffs of all the clinical centers who contributed information for this. And then the leadership of the data center program, Andy Todd, Susan Teitelbaum, who actually prepared the original proposal for this project, Nancy Sloan, who did a lot of the analysis and writing of the paper. And of course, we want to thank the responders, both, of course, for what they did starting on 9/11 and afterwards, and also for talking to us, giving their information to us, helping us to get their medical records. And so again, very much of a team effort. I also would like to take a moment to acknowledge the contributions of Steve Levin, who probably a lot of you may have known, who was a occupational medicine physician at Mount Sinai, and who was one of the ones who first realized that there was a problem and that something needed to be done, both in terms of taking care of the people who had gone there and seemed to be starting to have some breathing problems, and also that careful monitoring of these responders needed to be done. And he worked with a lot of the other people who are now organized the other sites and became the program, ultimately evolved into the program that is now funded by NIH, and that supports all this. And just as an aside, the vision, last week I saw on the news that it was the 1-year anniversary of that train wreck in East Palestine, Ohio, that led to a somewhat similar situation with a big cloud of probably toxic dust. And the impression I got, maybe if there's somebody here, it may well be, who knows more about it than I do and what's going on there, but the impression I got from the news reports is that I didn't hear anything about people with the kind of vision that Steve and many of the other starters of these programs had. And I don't know what's going on there in terms of finding out what actually happened to those people. But again, maybe in a discussion, if somebody can enlighten me about that. Okay, so just to review, because it's complex, now we have this big, well-organized program that is funded by NIOSH, and we have multiple data centers, we have multiple clinical centers of excellence. I work in what's called the General Responder Data Center at Mount Sinai, and we collect data from a number of local sites, including at Mount Sinai, at SUNY Stony Brook, at Northwell, also on Long Island, and at Rutgers in New Jersey. So all of their data files into our data center. There's a separate program, which was already mentioned, and I'll talk about some of the work that they did at the fire department. They have their own data center. There's another program, which I won't talk about much today, about other people who were in the area for whatever reason, whether it was living, going to school, working in other situations, etc. And there's a program that's taking care of looking after what happens to them. There is also, and you don't see an arrow from this, there's a national providers network which provides monitoring and treatment for the responders who, in the beginning, there were responders from almost every state, and so there needed to be set up a place or a system for looking after them. So there are providers scattered across the country who give them monitoring and appropriate care. At the moment, their data for research doesn't come in, but we're working on a system to set that up so that their data will be included in the future. And this slide doesn't show the other program that was mentioned at the New York City Department of Health and Mental Hygiene, with the registry, which I'll talk a little bit about also. Okay, so what I'm going to do today, tell you a little bit about how we got interested in this question, a little bit of background about autoimmune diseases and what's already been done, and tell you a little more detail about how we set up our study, what we found, and then a little bit of discussion and conclusions and next steps. So, all right, so we already said that the World Trade Center Health Program now provides annual monitoring to a variety of people who were exposed to whatever happened there at 9/11. And the general responder cohort, the local cohort, is quite large. It's a little more now. It was a little more than half at the time we published the paper, of 120,000 people that were being monitored. And like the other sites, we also saw the clinicians were noting that they seemed to be seeing more cases, what they called autoimmune conditions, who were coming in for the monitoring. So we did a project between 2017 and 19 to try to find out more about that and what was actually going on. So just to review a little bit of what we did in Morris. So first of all, sorry, I think I went too far. Okay, so autoimmune diseases, there are a variety of diseases and different people make different lists of what constitutes an autoimmune disease. And there are probably at least 80 of them. And what they have in common is that our immune systems, which are beautifully evolved to protect us against almost any kind of foreign attack, like whether it's infections or toxic materials that we might be exposed to, either breathing or other kinds of contact, and which works very well in general, but every once in a while it sort of breaks down and our immune systems end up attacking our own organs, tissues, and cells and causing lots of problems. The exact causes of these diseases are not really fully understood, and there are a number of things that seem to have something to do with this, whether it's family history, genetics, history of certain infections. There are some medicines that pretty clearly cause specific kinds of autoimmune diseases. A big factor seems to be, and different studies have attributed anywhere from 40 to 70% to environmental exposures. All these things may work together or separately to increase the risk. So they're fairly common. Up 3 to 5% of Americans, again, depending on how you define which diseases are on your list, can have autoimmune diseases. They can be very debilitating, require lifelong care, and they can be life-threatening. So we have treatments for a lot of them, but the treatments can have significant side effects. The treatments are generally sort of nonspecific, either symptomatic or things that suppress our own immune system because it seems to be overreacting. And one of the problems, of course, with that is that then it could make us more susceptible to infections and other things that the immune system is supposed to be protecting against. And so far, we don't have any definitive cures, although there have been some recent work that's pretty interesting. And they're based on, people may have heard of what CAR T therapy for cancers, where it's very complicated and expensive process, but they take immune cells out of the patients and put them in the laboratory, separate out the relevant ones, and they modify them and then stimulate them to increase and multiply, and they develop cells that, for cancer, that go back and specifically attack the cancers. And this seems to be working quite well for a number of cancers, although as a warning, there was the FDA noted, I think just as recently as last week, that it looks like in rare cases, these CAR T therapy can actually cause cancers on its own. So that needs to be looked into. But anyway, they're trying to apply this same technology to autoimmune diseases. And so that may be a definitive therapy that will be coming along, but lots of questions remain. Okay, so the other thing that the other reasons that these are important is that they have a big burden, both financial, emotional, symptomatic on the patients, their families. And so this is a significant part of national healthcare costs. They disproportionately affect women, particularly reproductive age women, and also for reasons that at least I don't understand very well, they also seem to be more common in left-handed people. And several of them, including Crohn's disease, ulcerative colitis, systemic lupus, multiple sclerosis, etc., disproportionately affect minority groups. So it's another reason to be concerned about these. Excuse me. All right, so what's been done so far? The fire department program did a very similar study to what we did on their cohort of firefighters and EMS workers, and they had over 15,000 people that were in their study at the time they did it. And they limited it to what they called systemic rheumatologic conditions, which I'll show you in a minute. And so they found 59 cases in their population that were confirmed by a specialist, by a rheumatologist. And what they did is they compared people who had high exposure to the dust cloud versus less exposure, and a couple of different ways. So looking at people who were on the site for at least 1 day a month for 2 or more months versus people who had less than that. And when they did that, they found that the people with high exposure were more than twice as likely, the odds ratio of 2.4, to have these rheumatologic conditions. And then doing a similar analysis with a different definition of just people who were exposed to the heaviest dust in that Tuesday morning, versus later exposure. And again, it was almost twice as likely, but the numbers were a little smaller, so the confidence interval was a little wider and didn't quite reach significance, but they strongly suggestive that the higher exposure was more likely to result in these conditions. And they did, again, similar to what I'm going to tell you we did, they compared to an external population, this Rochester, Minnesota population. But in that situation, they found that the odds ratio was 1, essentially that these conditions were equally common in their firefighters as they were in the people in Minnesota who were not exposed to the World Trade Center. And these are the conditions. So they had these 59 conditions that they list here. Rheumatoid arthritis was the most common. I won't read the whole list, but these are, if you're familiar, these are diseases that are fairly widespread, that affect lots of parts of the body, that cause lots of problems. And this is what they found in their population. And there was another similar study by the Health Registry from the New York City Health and Mental Hygiene Department. This, as people may know, is essentially a series of surveys and questionnaires that they send out. And they send out a specific survey, again, about what they called systemic rheumatologic conditions. And they got 43,000 responses to that. Their population, as I understand it, and again, people who may know more, please correct me, but this is essentially anybody who was in that area during that specific time. So it's there's some overlap with the people in the other studies, but it's a broader outreach. So they found in their questionnaires, they found over 2,700 people who said by self-report would look like they had, after 9/11, a systemic autoimmune disease. They were able to get medical records for a little over 1,000 of those. And after reviewing those, they confirmed 118 of these. And they did a similar high versus low exposure comparison and found numbers pretty similar to what the fire department found, that when they did the dust cloud as high exposure versus late exposure, they found that the people who had the morning dust cloud exposure were, again, close to twice as likely as the people with later exposure to have these rheumatologic conditions. And again, slightly different analysis. They did an amount of time that people were there, and again, got a very similar number. And so they also saw evidence that the people who had the more exposure were more likely to have rheumatologic diseases. And in these papers, they did not do an external comparison. So that's what was known at the time that we started our project. Wait, here's their list of diseases again. And again, it's pretty similar. Rheumatoid arthritis was the most common, and lupus, Sjogren's syndrome, some muscle diseases, and some other diseases. Scleroderma, people probably know, is a disease where the skin becomes very thick and impairs mobility and difficulty in doing lots of things. Okay, so we, having seen what these groups had done and keep continuing to hear reports from our clinicians that they thought they were seeing more than they expected of a variety of diseases, we said maybe we should do something along the same lines. We thought we have potentially at least as large a sample size, that by the time we got started, more time had elapsed since 9/11, so there was maybe more opportunity for these diseases to develop. And we also said, well, maybe we should look at a broader range of diseases, not just rheumatologic, but in areas. So we also decided to look at endocrinologic, autoimmune diseases, gastrointestinal, neurologic, dermatologic, and then various miscellaneous. So, okay, so we did fairly elaborate screening and trying to determine these diseases. One of the things about a lot of these diseases is, for some of them, there's a very specific and relatively easy way to decide, does somebody have it or not? In other words, you could do a biopsy or something, but a lot of them have these sort of menus and checklists that they say you should, and I'll show you a couple of them. You have these specific elements, then you have it, and otherwise you don't. And some of them are a little vaguer than that. They say these are the things you should look for, but they don't specify what the sort of minimum criteria are. So we could, with the best documents and with help from some of our experts, we could classify people as definite, highly probable, meant that what I just said, these guidance documents were a little vaguer and it was less explicit, but you could still say, this certainly looks like what they're talking about. Then we called probable things that had sufficient data to be able to say there was something going on there, but we were maybe missing some of the important elements, but we did have at least maybe a specialist physician saying that they had it, that the member is on appropriate and fairly specific medications, that they had the right kinds of tests. And again, one of the things that the results weren't always available in the chart, and the member gave a history that fit in. And possible, we said there's some suggestion here, but we don't have everything we need. Maybe some key result was missing. We didn't have enough information on the treatments, or we didn't see in the record all the symptoms that we needed for the list. And it could be that either it's just not there, or because the condition was still evolving, and at the time we did this, maybe they didn't have enough, but maybe they would develop more later. And then for some of them, it was pretty clear that they were that you didn't have it. It was either there wasn't enough evidence there altogether, or that we found something else. We were pretty able to say they don't have it. The other thing we looked for was to try to be clear about when they got it, or when it was diagnosed at least, and was that before 9/11? So if it was, then we didn't include that. And sometimes it just wasn't enough information to be able to tell for sure. And again, maybe they would develop later, or more information could evolve. So here's an example of a pretty easy to use, once you spend some time looking at it, classification for rheumatoid arthritis. And you get points, various numbers of points for each of these characteristics. And this worked pretty well. You need certain blood tests like rheumatoid factor, and other blood tests that they do for inflammation. How long was it present? One of the things that was sometimes frustrating is you get different numbers of points according to the exact number of joints that are affected. And sometimes you could tell that from the chart. Again, we never examined the actual patients. We looked at their charts, and sometimes they would say multiple joints, and we had to try to decide, did they get 2 points or 3 points for this, et cetera. But so, and I'll tell you in a minute, we spent a lot of time trying to figure those kind of things out. Some of them were a little easier. Psoriasis is the skin condition, is one of the things that we included. And here's a picture of somebody with psoriasis. Psoriasis is considered very easy to diagnose, at least by a dermatologist, just by looking at it. The classic, these scaly patches, often on the elbow or the knee or the neck. And if a physician sees that and says that looks like psoriasis, that's considered sufficient for the diagnosis. You probably don't even need to be a physician to be able to say, yeah, this is psoriasis. And then there's psoriatic arthritis, which has a somewhat similar list to what I showed you for rheumatoid arthritis. You only need 3 points for somebody to be classified as psoriatic arthritis. And if you have psoriasis, the skin condition, that gets you most of the way there. And then you need either there's some characteristic nail changes. The rheumatoid factor is a test for rheumatoid arthritis. You get points for that in rheumatoid arthritis. And you get a point if you have a negative rheumatoid factor, you get a point towards psoriatic arthritis. And then there's some characteristic changes that you get on x-rays. So, okay, so with that, the other thing that we did, just to be clear for everybody or to remind everybody, we did, like the fire department and the city health department, we did a nested case control study within our cohort. The cohort for all of us was the people who were exposed on 9/11, and each of these studies does similar things in the sense that they check on what's happening to people over time. And so a nested case control study, we looked for cases. In our case, it was autoimmune conditions, the red dots, and then we looked for people to compare them to within the same cohort who did not have autoimmune conditions. And then we looked to see who had high exposure versus low exposure and to make some comparisons. So a little more detail. So again, we did this high versus low. It's self-reported exposure. People told us when and how much time they spent there. And there are, as we already said, different ways of classifying as high exposure, either because they were in the dust cloud the first morning or according to the number of days they actually worked there. And for each case, we looked for within our database of the monitoring visits from those 5 centers that I showed you at the beginning, we looked for 4 controls without autoimmune conditions for each case. And we tried to find controls that were similar age within 2 years, the same sex, race or ethnicity, and who had been in our program for roughly the same amount of time. And we, again, technically, the controls could be matched to more than one case. And cases could serve as controls before their date of their first disease. And then we did, again, the team members, conditional logistic regression to look at the risks versus high versus low of at least 5 of those 6 domains. The 6th one, we had so few cases that we couldn't really do these kinds of analysis. We also tried adjusting these models for a variety of information that we did have, including body mass index, the dates, whether or not they had post-traumatic stress disorder, PTSD, because there is evidence that people with PTSD are more likely to have some of these diseases. We also looked at smoking status and occupation on 9/11 as some kind of a measure of prior occupational exposures. And then we did some sensitivity analysis looking at different definitions to see whether that made a difference. Okay, so then we looked at these rates and we tried to compare those to the US Census in terms of age and sex distributions. And again, we were able to do this for 5 of these 6 domains. And again, some technical details about how we calculated the numbers of years of exposure for people when we stopped collecting, obviously at their death or their last visit, et cetera, and calculated 95% confidence intervals for all of these things. And then we used, again, to remind people, the standard incidence ratios to compare, which is the ratio of the observed number of cases that we had in our study group to the number of cases in the comparison group. And an SIR of 1 indicates that the number of cases observed in the study population is equal to the number of cases that you expected in the comparison population after adjusting for whatever you adjust for. And as I think I said, like the fire department, we compared these age and sex adjusted SIRs to this Rochester project from Minnesota. And one of the problems with this particular comparison, one of the problems that we all have with this kind of work is that there doesn't, so far, we don't really have a really ideal comparison group. And that may be part of the reason that we were finding or not finding differences, that the Rochester population, for example, is ethnically diverse, less diverse than our responder population. And then for the case review, in other words, how carefully or how similarly were the case determinations made? And I already said a little bit about this, that we had 3 clinically trained professionals who reviewed all of these, first the monitoring data that we had on everybody, and then the ones who we got the medical records for, to compare those to the criteria for diagnosing each of these diseases. And we consulted various specialists to help us when we had any questions. And just to compare, in the Rochester, they, because of their healthcare system there, they had very good records, both inpatient and outpatient, for their, and they had specialists review them. So it was probably pretty close to the same amount of rigor, that they used standardized criteria, and they had to be present on at least 2 visits for them to consider them confirmed cases. Okay, so a little bit about our group. So we had in this study over 41,000 people whose monitoring records we looked at. And there, as our population people probably know, was 80, or mostly men, 86% men, 14% women. Their mean age on 9/11 was 39 years, and their mean age when they had their first diagnosis of an autoimmune condition was 47. And most of them were married, as I said, men, white, non-Hispanic, and never smokers. And the largest employment category on 9/11 was protective services. And in terms of their exposure, more than half could be classified as high exposure if you used either exposed to the dust cloud or worked more than the median number of days that everybody worked. And out of that, if you looked at just each of those separately, 21% qualified in terms of high exposure. If you look just at the dust cloud, and 52% could be considered high exposure if you looked at in terms of median days worked on a site. And from the math, you see that probably 10 or 11% had both. So that's how it's to fit into this category. Okay, so what did we actually do? So because we had charts, monitoring visit charts or data, not medical charts, the first thing we did to go through that was we worked with some of the data analysis people in the data center to screen the visit data that we already had all computed. So we looked for both names of the diseases with various spellings because people didn't always spell them exactly the same way. And we spent a lot of time trying to improve these screening criteria, we looked for the names of the conditions, the names of the medications or combinations of both. And so this ultimately ended up giving us over 9,000 out of these 41,000 who looked like they might be. And we also had, I said that some of these were pointed out by the clinicians, so we had an additional 49 that were referred to us specifically by their clinicians. So a little over 9,200. And then we looked at all the information that we got either from the clinicians or from the data records, the monitoring records, and we further weeded it down to 2,300. It still looked promising. And then from there, whoops, sorry again. Okay, so out of those 2,300, we were able to initially again exclude about half, a little over 1,100, either because it was clearly pre-9/11 that they got the diagnosis, or that we were never going to have enough to do it, that these were diagnoses that some people considered autoimmune, but that we didn't have. And very few, only 17, said, no, we don't want to participate and give you our records, and then a few other things. So there were 1,100 that we got or tried to get the case records. And out of those 1,100, we were able to give one of our 5 categories to 734, and we excluded an additional 400. Either in a lot of situations we couldn't get the records. Occasionally it was because the doctor's office, despite repeated requests, still didn't do it, but mostly it was because these were old records and nobody had them anymore. Again, a few more were included, a few more were found to be pre-9/11, and even when we got the records, and some of them we just didn't have enough information. We found some other diagnosis. But of the 734 that we were able to identify or make our determination by that chart that I showed you, we called 185, we said were definite. 351 we called highly probable. Another 100 were probable. 25 possible. And then unlikely or negative was 73. So of the cases, then we called the definite and highly probable. Okay, so this is, again, the most common was the rheumatologic category, but we had quite a few in the endocrinologic and fewer in the gastrointestinal and neurologic, moderate number of dermatologic, and in the other category we had 19. So there were 657 diagnoses in this population. Occasional patients ended up with more than one diagnosis. So here again, the rheumatologic was the most common category, and rheumatoid arthritis itself, like the other studies that I showed you, was the most common disease. And we had psoriasis was in this category, the next most common. And here again, some of the other names you've seen before: systemic lupus, spondyloarthropathies, vasculitis, etc. And in the endocrine category, we had 154. All of them were, there's 2 forms of thyroid disease: Hashimoto's autoimmune thyroiditis and Graves' disease, which affects the eyes in addition to other things. And then in the gastrointestinal, the majority were either Crohn's disease, in other words, were they inflammatory bowel diseases, either Crohn's disease or ulcerative colitis. And we had a few, not enough to do any calculations with, but a few cases of autoimmune gastritis, pernicious anemia, which is basically more or less the same thing. And neurologic diseases, we had multiple sclerosis, a disease of the peripheral nerves called chronic inflammatory demyelinating polyneuropathy, CIDP, abbreviated myasthenia gravis, and a couple of others. And the dermatologic, we had cutaneous psoriasis alone without the arthritis, and cutaneous lupus, and then a small number of a couple of other diseases. So that's our spectrum of autoimmune diseases that we Oh, wait, sorry, I didn't give you the last one. So we had a few small numbers of renal, hematologic, hepatic, and eye diseases, but again, very small numbers. So, okay, so when we did the analysis that I showed you before about high versus low dust cloud exposure, what we found in our population was that we didn't find an increase in the high exposure. You could see most of these numbers. This is everybody, and then this is separated by sex. And it didn't make much difference that all of these numbers are around 1, and with the confidence intervals including 1. So basically, we couldn't conclude that any of these were more likely in the people with high exposures. A few of these look a little higher than 1, but they're smaller numbers, and the confidence intervals are pretty broad. So you can't really make much in the way of conclusions from this. So we didn't see an increase in the high exposure, and we'll talk about possible reasons for that. And when we compared to the Rochester population, what we found is that in each of these categories, that the rates of these diseases, at least as we determined them in the number of the data that we had, that in fact, all of these diseases were less common in our responders than they were in the so-called normal population of people in Rochester, Minnesota. So we didn't see a difference. So, all right, so the summary of our results is that we found a broad array and a fairly large number of carefully confirmed autoimmune conditions in our population, but we did not find a significant association with high exposure. And we also found that lower rates compared to the Rochester external comparison group, which was again the best comparison that we could come up with. So we didn't confirm the increased exposure, but we know we had a lot of exposure, a lot of broadly diverse population. We had what we considered a pretty strong review of the case status. We had a large number of cases. We did this without knowing anything about their exposure, so we were blinded. So we tried to reduce the potential bias in that situation. The nested case control approach that we used is something that's again, it's widely used. We tried very carefully to equalize the observation time, to try to minimize any kind of selection or reporting biases. And whenever we varied these analyses to see using different definitions, it didn't seem to make that much difference. So we had pretty good follow-up rates. So and we did find things that do work consistent with the literature, that the rates are higher in women than in men, which makes us, again, gives us some more confidence in our results. That although, I mean, again, we have to be careful and admit that we didn't get all the information we wanted, that our initial screen, in fact, may have, we tried very hard, may have excluded people who would have ended up having these diseases. The exposure measure is pretty inaccurate, I have to say. I mean, we don't have any specific measures. We asked people, when did they arrive? How long were they there? And this is based on their memory. And there was a lot of variability in what it was like at different subparts of the site, and in terms of the protective equipment that people may have worn. So there were a lot of potential issues in our high versus low exposure classification. There, already mentioned, there are a lot of concerns that we all share about the similarities or the dissimilarities between our responder population and the Rochester population. And again, there may be some differences in the way the cases were confirmed at the two sites. So we really still are looking for an ideal comparison group. And people may know that Susan Teitelbaum from our site had the idea of trying to put together a better comparison group, but then COVID came along and made it essentially impossible to try to recruit people. So we're still looking for the ideal comparison group. But I think one of the lessons is that, and it's still, that initial clinical impressions are not always confirmed once you try to do the careful case ascertainment, but that shouldn't discourage us from continuing to try to look. So basically, that's how we're going to find out. So again, there's some agreements and some disagreements that the fire department and neither of us found elevated rates compared to Rochester. And the FDNY and the registry did find a relationship between high exposure and rates of the diseases that they looked at, but we didn't. And again, there are lots of possible reasons for that. There were differences in the populations that each of us included. There may have been differences in how we determined the cases. There may be differences, again, we already said, between the responders and the comparison populations, and hopeful that other people here may be able to propose other things that may have been factors here. So where do we go from here and what do we conclude? So maybe what we should consider is if we put together our data, the fire department data and the registry data, and plus we will soon be getting data from the national program. So maybe by combining all of these, so of an individual patients or subject meta-analysis, we could get some better data. I mean, things, again, our assessment was the most recent one, but that ended in 2019. So we have another 5 years or so of exposure. Maybe there's more information that's been collected. So we need to continue to try to do the kind of research looking at exposures, and particularly things with long latent conditions. So in these programs, we think continue to provide important information, and the GRC anyway is continuing to get enroll new members as people age and decide they want to find out more about what's happening. So that's, excuse me, sorry again, that's what I wanted to present. I thank you for your attention, and I'm happy to try to answer any questions that people might have now. And if somebody thinks of a question later, here's my email address if you want to send me an email with a comment or a question.
Thank you, Dr. Sachs, for your very informative presentation.